My name is GLADYS and I serve as the head of the National Cancer Registries at the National Cancer Institute of Kenya. And I'm also privileged to serve as a regional trainer for the World Health Organization at the International Agency for Research on Cancer. And I'm privileged today to present to you our cancer statistics dashboard for Kenya. A brief background about the work that we have done over the last 2 years. This data comes from the country. This is organic data from the health facilities within Kenya. 79 facilities out of 94 have been able to contribute their data to this dashboard. So this is majorly hospital-based cancer registry data. All our patients move to different hospitals within the country, including the regional centers that have been established to be able to seek care. So there is where we have captured this data to be able to showcase this dashboard. So part of my background is to convert clinical data into useful data that can be used for decision making. So this dashboard is not just charts and figures, but data that can be used to lead and for policy and basically to support the cancer patient who is at the center of this institute. Now we are able to know who the cancer patient is in this country, where they are, and what challenges they experience in seeking care. So we know, and we have shared some fact sheets with you. In this dashboard, we present data for 2024 from all the facilities, and we have over 14,000 cases for specific males and females. And for this particular part of the dashboard, I want to showcase the most common cancers that we found out in the country. Each case here represents a cancer patient who has been diagnosed in this country and who has visited one of our facilities. So breast cancer presents as the most common cancer, followed by cancer of the cervix, esophagus, prostate, and colorectal. Those are the 5 top cancers in the country. We are also able to showcase where exactly the patient comes from in terms of county. So these are the county of residence. Even if the patient comes to Kenyatta from information on their place of residence, and now we can be able to say we have this number of patients who suffer from this particular cancer in Samburu, for example. We also are able to tell the gender disparities as well as and the age distribution as well. So we have been able to find out that of course we have more women diagnosed with cancer, especially for that particular year, but generally in the cancer landscape in Kenya than men. This is generally because of breast and cervical cancer, which takes up a lot of burden and a lot of the cases. So we have cancer in terms of age group presenting quite early for the females, starting from about 20 years old, all the way to over 40 years old. And that is again because of cancer of the cervix and cancer of the breast, and specifically for the men from ages of 40, where we see cancers of the prostate, and 60 and above for cancers of the esophagus. That is where the major burden is. So for the females, a lot of these cancers is happening in the productive years. And these are young mothers, these are young wives, and for the men is when they are trying to settle down after retirement, and this is a great burden in our nation. So in terms of staging, we are seeing a lot of missing data. And also, we are finding out that most doctors know the stage, but they are not documenting it in the file. So we are looking at hopefully standardizing all the reporting formats so that this data can be captured both on paper and now that we are transforming to electronic methods, that this can be shared electronically and cut down on the paper-based nature that we've had and experienced. Again, we know exactly where the patients have been seen. So we can account for the patients who have been seen in different facilities within the country and also where the most burden is in terms of county. So in this and in the sheets that you have, we have tabulated the cancer incidence per 100,000, and there we standardized the cases per population, and we found that Kiambu, Nyeri led in the highest burden of cancer in the country, followed by Murang'a and then Uasin Gishu. So we have some very new information that actually requires even further research, even further interventions to look at what is actually happening in these counties. We also saw the counties that had the lowest incidence. And these were the more arid counties like Mandera, Samburu, Wajir, West Pokot. This is where also there's very limited resources, limited reporting, but it does not necessarily mean that there are no cancer patients there. Just that the resources are limited and then they are quite far from most of the treatment facilities that are available. In terms of basis of diagnosis, all the data, about 97.5% on this dashboard were diagnosed definitively using histology and cytology. Some of our cases, 2.5%, were clinical investigations like radiological procedures, and this formed the basis of diagnosis for our dashboard. In terms of treatment, of the 14,000 cases, most of the patients utilized chemotherapy and radiotherapy at 12.1%. Generally, most of the sites, most of the treatment centers have access to chemotherapy, and with the recent infrastructural support from the government, now we have more radiotherapy machines, and we hope that in 2025, when we analyze the data, we'll see a big difference in terms of treatment accessed and treatment modalities. In terms of the cost of treatment, how are the patients financing their cancer treatment? So we collect information on how the financing happens. Are they using SHIF? Are they using cash? Are they using any other insurance? And we found that over 77,000 of the patients are using SHIF. And that's a good thing even for us, because then they don't have to go into their pockets and pay for treatment. A smaller percentage of patients still use out of pocket, and I think that is when the insurance runs out, and then even a smaller percentage uses entirely other insurance companies, the private insurance. So this is what we have. We are able to look at each county, and in each county which types of cancers and which age groups and which types of basis of diagnosis, which facilities, and generally the landscape of cancer in each county within the country. Even if there is no treatment facility, the patients who come to Nairobi, those who go to Mombasa, those who go to Eldoret for treatment, we are able to have that information on their place of residence and therefore link them back to their counties. Thank you very much.